Thank you, Rashmi ji, for such a kind introduction. So, I'll just share my screen. Am I able to? So, good evening, everybody. So, I'm Dr. Vivek, as Rashmi ji told. So, I'm working as a transplant pulmonologist with KIMS Hyderabad. And today, Dr. Rath has made my job very easy because he has covered most of the things for me. But I would like to just concentrate on the lung involvement in scleroderma. So the outline for discussion would be what are the problems which occur in the lungs in scleroderma patients. Predominantly, it's the involvement of the lung interstitium or the lung tissue, we say what we call as the interstitial lung disease or the pulmonary fibrosis. Scleroderma may involve the lung blood vessels causing pulmonary vascular diseases. And of course, lung infections also remain one of the concerns. We'll be also just covering about how do we screen for these problems, though Dr. Rath has covered these things in quite a detail. And we will be devoting some time to management of these lung conditions, that how do we manage once we have the lung involvement because of scleroderma. So some changes in the lungs is seen in patients with scleroderma very commonly, but around 13 to 15% of patients may have severe lung involvement in the form of pulmonary fibrosis or pulmonary arterial hypertension. The main symptoms with the lung involvement in these patients is shortness of breath. That is, we tend to get out of breath on routine work. Gradually, as the involvement of the lung progresses, our exercise capacity or the capacity to exert reduces, and we tend to get breathless with minimal exertion. The other symptom is a cough, which is predominantly dry. The cough typically is brought on by exertion initially, and later on, as the lung involvement progresses, it may be more hacking. And of course, one of the symptoms of advanced lung involvement is desaturation or loss of drop in our oxygen saturations with activity. So this slide just shows that amongst all rheumatological conditions, scleroderma is one condition which has the highest propensity to involve the lungs. So when we talk of lung fibrosis, this is what's the investigation to diagnose the lung fibrosis is a radiology. So X-rays, though not very sensitive to diagnose pulmonary fibrosis, but may show these diffuse white patches in the lungs. CT scan is a much better modality to diagnose pulmonary fibrosis. And here what we see is that the lung starts shrinking. The lung starts showing some more white bands into it, which is, I would say that these bands, the lung tissue is becoming hardened and thicker, and that is responsible for the symptoms with the lung involvement. So how do we suggest, how do we go about these patients? That patients with systemic sclerosis should have a PFT and HRCT. If they are normal, as Dr. Rath said, that 5 years are very important. So if they are normal, then we just can follow these patients on a yearly PFT basis. If the PFTs remain normal, I think we are happy that the lungs are holding on well. There is no compromise of the lung function. But if the pulmonary function tests and the values, what Dr. Rath mentioned, the most important numbers which we are looking at is the FVC, which is the forced vital capacity or the capacity of the lungs to expand, and the diffusion, the DLCO, that how the gases are diffusing across the lung membrane, because you would understand that one of the basic functions of the lung is for the gas exchange. That is, the oxygen moves in from the airways, air sacs, into the blood, and the carbon dioxide moves from the blood into the air sacs for the respiration. So if these tests are normal and the lung disease is limited, then we recommend a PFT to be done every 3 to 6 months, depending on how the lung functions are behaving. If it's stable for 5 years, we can switch on to a yearly PFT. But if it is a progressive disease, then of course treatment. If there is an extensive lung disease at the starting, then of course patient needs to be put on treatment. Dr. Rath has covered that much in detail. The second problem with these lungs in patients of scleroderma is pulmonary hypertension. Now, don't go by the word hypertension. It's not a normal hypertension. It's the high blood pressure of the lungs. Because the lungs are becoming, so there can be a couple of reasons for patients developing pulmonary hypertension or high blood pressure of the lungs. One is that if there is an interstitial lung disease or pulmonary fibrosis setting in because of systemic sclerosis, the lungs tend to become harder, stiffer, and smaller. So the resistance which these blood vessels have increases, and because of this resistance, the blood pressure starts going up. The other reason can be that scleroderma per se involves blood vessels and can cause pulmonary hypertension. The pitfall of these increase in blood pressure of the lungs is one, that the heart has to exert more or has to apply a higher force to pump the blood into the lungs because of this increased resistance. And this, because of the change in the mechanics of the blood flow, the patients tend to have breathlessness, reduced oxygen tension, and as this condition progresses, they may start developing swelling of the feet, some liver dysfunction, and other symptoms. So how do we go about it is, whenever we diagnose somebody, we do a baseline PFT and an echo, let the patient be seen in a PAH clinic, and then we should follow these patients up. If they're stable, follow them up with a yearly PFT and an echo. If the values are abnormal, if we are getting signs of pulmonary arterial hypertension, patients should be started on treatment. Now, infections will always remain a concern in patients who are on immunomodulation or immunosuppression, particularly very, very important with lungs, because this is one of the organs which is completely open to the external environment. So whatever is there in the air, we keep on inhaling the same air. And if because of any reasons, our body immune mechanisms are compromised, then we are more prone for infections. So what I want to stress out here is that apart from the common bacterial infections, patients on immunomodulators, drugs like MMF or tocilizumab or even steroids are prone for opportunistic infections like fungus and atypical organisms. By opportunistic, I mean that these infections usually will not affect normal human beings. And the signs and symptoms of infection with these organisms is not that pronounced. One of the most common symptoms we associate with infection is fever, but fever may not be a very, very prominent symptom in patients with infection, particularly when they are on immunomodulatory drugs. So the diagnosis mainly relies on the symptomatology. So if you feel, as Dr. Rath was pointing out, if you feel that in the preceding few days you have not been feeling that well, which you usually used to feel, you should consult your doctor, talk to your doctor. If you develop some new cough or your breathing is not there, what you used to feel, you should talk to your doctor. And based on the symptomatology, we need to do some directed investigations, either by radiology, which is a CT or X-ray, some blood investigations. And of course, sometimes we may even need to culture, depending upon the site of the infection we are suspecting. What are the strategies to prevent these infections? So we recommend that certain prophylaxis should be given to patients who are on immunomodulatory drugs, like patients of scleroderma. and certain vaccination should be done. So all patients of scleroderma should be given a drug called as Septran. It is, by common name, it is called as Septran or Bactrim. Pharmacologically, it is cotrimoxazole. Now, this is one particular drug which has been shown to be very, very effective in preventing an infection by organism called as pneumocystis, which particularly infects the lung and only infects people whose immune responses are compromised because either of the disease or because of the medical interventions we have done. And if we use Septran, the chances of the protection which this drug affords is close to around 99%. That is, it practically takes away the chance of developing a PJP infection. Patients who have had fungal colonization, who have documented to have some fungal colonization in the airways, are sometimes put on inhaled antifungal drugs. It's not given by injection or tablets. They just need to use it by a nebulizer to keep the fungus under control. And of course, all patients who are on immunomodulatory drugs should receive regular vaccinations. Once in a year, they should receive their flu shots. And of course, the pneumococcal vaccine, there's been strong recommendations of using pneumococcal vaccines in these patients. Maybe later on, we may hear something about this COVID vaccine as well. Now, how do we go about managing these patients of scleroderma who unluckily have developed some lung involvement? So I always believe that the management of these patients is based on 4 pillars. And all these 4 pillars, all these strategies have to go in tandem. They are not exclusive of each other. We have to look at all the 4 things together to get the maximum benefit out of the interventions and to help the patient lead the best possible, have the best possible quality of life. So these 4 pillars are, of course, the drugs or the medicines which your doctor will always prescribe you. But the things which I have realized is overlooked or is not, is not stressed upon that much is one is the nutrition, the pulmonary rehabilitation exercises, and supplemental oxygen. So drugs I will not go into detail because Dr. Rath has already covered it in very, very great detail and he has explained it beautifully. So apart from your medications, as Dr. Rath said, if your lung involvement is there, you might be prescribed some antifibrotic medications like nintedanib or pirfenidone. He has already explained the benefits of using these drugs. What I just would reiterate is that these drugs have to be taken for a long period of time. Don't get disheartened if you're not seeing appreciable change in your lung condition within a month or 2 of using the drug. You should be using the drug at least for 6 to 8 months to see some appreciable benefit on your lung condition. And of course, if there is pulmonary arterial hypertension developing, you might be put on some anti-PAH drugs or some drugs to increase your urine production, which we call as the diuretics, if there is PAH. Now, coming on to the nutrition. So the basic ideas of diet for patients who have lung involvement because of a systemic disease or who tend to develop lung involvement in the form of pulmonary fibrosis so we should achieve and maintain a healthy BMI of around 22 to 25. So we should ensure that we are having a well-balanced, nutritious diet, which is balanced in terms of energy as well as proteins. So typically, a moderately active individual should have somewhere around 2,000 calories per day with around 1 gram per kg body weight of protein. So the protein the protein energy should not be accounted into the total energy of the food, because this protein, what we are consuming, we want to divert this protein or use this protein entirely into bodybuilding or strengthening our muscles. We should eat nutritious and a balanced diet with, as I said, plenty of proteins, fresh fruits, vegetables. One of the problems what scleroderma patients have is they may have some esophageal involvement or they may feel full. with meals. So we advise them that we should have small meals more frequently rather than having big meals in one go. One of the reasons which is particularly important with people who have lung involvement is if we have a big meal, it tends to distend the stomach, which hampers the movement of diaphragm, which is the main muscle for breathing. So it's not able to come down that much. The lungs are not able to expand fully, and patients may feel more breathless after having a meal. We should limit our sodium intake because higher salt or sodium intake leads to water accumulation, which may worsen our pulmonary pressures and increase our breathlessness. Fiber in the diet should be adequate so that constipation is avoided, because if the patients remain constipated, they feel bloated, and it has a bearing on their breathing. We should limit caffeinated drinks and acidity-causing foods, because hyperacidity is a problem. With hyperacidity and some esophageal involvement, reflux can happen, the acid reflux, by which I mean that the acid can travel to the upper tracts. And if this acid trickles into the lungs, it has been seen that this is one of the important factors for the lungs to get damaged. Now, coming to the pulmonary rehabilitation exercises. So pulmonary rehabilitation, so these are non-pharmacological interventions which lead to an improvement in the exercise tolerance, physical capacity, and ultimately the quality of life. So what I really want to stress out is that there is no drug involved into it. It does not do anything to your basic disease, whether it is scleroderma or whether it is lung involvement as a result of scleroderma. What it does is that it improves our whole effort is to improve your exercise tolerance, your capacity to do things, which ultimately translates into a better quality of life. That is, with whatever functions we have, whatever disease limitations we have, we are able to perform our activities in a much more efficient way than what we were doing. The program is individualized. It is designed for each individual. So before we design the exercise regime for an individual, there's a physical assessment of the individual done. We talk to the patient, look at how the disease, what is the stage of the disease, how involved the lungs are, how much this individual can do, and from then we try to build it up from there. And exercises are mainly divided into two: endurance or the capacity building, and the second is the body toning or strengthening. Usually we would recommend a 1-hour session for at least 5 days a week, and it goes at least for 6 to 8 weeks. Lastly, just a word about supplemental oxygen. I've seen that there's a lot of reluctance in India about using supplemental oxygen. And even patients who are using oxygen, they're not using it the way we recommend it to be used, or when oxygen can give them the maximal benefit. So any patient with advanced lung disease may require supplemental oxygen for various activities. Using oxygen does not mean that your disease has moved beyond a certain stage, that nothing can be done, or you become addicted to oxygen. Nothing like that. It just goes on to say that the disease has reached a level where the 21% oxygen in the ambient atmosphere is not able to suffice. It is not able to maintain the oxygen tension or oxygen pressures in your blood, which will be able to provide oxygen to all the tissues in the body. So supplemental oxygen should be used in all those activities which lead to a fall in your oxygen saturation to less than 90%. By this, I mean that, if you're sitting and your oxygen saturations are more than 90%, you don't need to use oxygen on that. But if suppose you go to the washroom or take a shower and see that your oxygen tensions have dropped to less than 90%, maybe 80, 85%, then you need to use oxygen on those activities. How much oxygen we should use is the amount of oxygen which gets our saturation to above 90 should be used. How much, what is the length of oxygen we should use? It is only for the time we are doing that activity. If on cessation of that activity, if the oxygen tensions are more than 90, we are happy, no need to use an oxygen. What supplemental oxygen do is it improves our capacity to do those activities which we are finding difficult to do, because it takes care of the fatigueness. The tissues are able to get enough oxygen, so we feel less fatigued in doing those activities. The other thing is, of course, patients who develop pulmonary arterial hypertension, it does tend to improve or at least prevent the worsening of the pulmonary arterial hypertension and reduce the load on the heart. Now, just a word about lung transplant. This is a really big topic. So, what I would just like to tell you is that lung transplant, a lot of myths are there about lung transplant, particularly in India. But I tell you it with a lot of confidence that for patients with advanced lung disease who continue to be symptomatic or their symptoms worsen despite being on maximal medical therapy, lung transplantation is a definite treatment option. Lung transplant not only improves the quality of life of these patients, but also gives them a better 5-year survival. So we do not offer lung transplant for a patient just to improve the quality of life. There are certain scoring systems which we have to use, and we have to produce this scores to the organ allocation agencies, which are government agencies, where we have to show on those scores. Those scores have to show that the patient's survival gets improved after a lung transplant. The success rate for transplant today is around 88 to 90%. In India, we have been doing transplants for the last 4 years now. So I have been associated with this program for the last 1 year, and as we have done 56 transplants in our current hospital in Hyderabad over the last 10 months period. And as a team, we have done close to around 284 transplants so far. And it is, of course, it's a big undertaking. We have to understand the transplant process. But what I can tell you is that lung transplant definitely is a very viable and a good treatment option, provided we choose our recipients properly, that they have to be in a window where they can be transplanted. Usually, there is a narrow window of around 2 years when these patients can be considered for transplant. If they shouldn't be too sick that they cannot handle the surgery, and they shouldn't be early, that the lung still still has functions which they can, they can survive with these lungs. So timing is very important. Choosing the patient is very important. And particularly about scleroderma, there's enough research now, enough papers available, which has shown that the results of lung transplant in scleroderma patients is very similar to the transplant results in patients for other medical conditions. Why I say this is there was some concerns being raised about skin condition, skin involvement in scleroderma, and how these patients would do once they have such a big incision for a surgery like lung transplant. But I think enough data has it has very similar results. With this, I would like to end. Thank you very much for inviting me here. And should you have any questions, please feel free to get it. Thank you very much.